Evening, everyone, and you're all very welcome to Croí's Living Well with Cardiovascular Disease series. And this episode will be focusing on heart failure. I am delighted to welcome this evening a diverse panel of experts. As I said, we're focusing on heart failure, and to that end, our experts include Ian Burnett, who is living with heart failure and here to share his experience and his perspective as a patient and somebody who's living with a long-term condition. We have Dr. John Barton, a heart failure consultant at Galway University Hospital, and Emer Burke, advanced nurse practitioner, heart failure integrated care at Galway University Hospital. And I'm also delighted to introduce our special guest moderator this evening, Aiste Streite, who is a heart failure patient, or should I say an ex-heart failure patient, and she will explain that herself, and is chair of the Global Heart Hub Failure Patient Council. Sorry, the Global Heart Hub my goodness, I'm getting tongue-tied, so sorry. She is chair of the Global Heart Hub Heart Failure Patient Council. Got that one right, it was a bit of a mouthful, of which Croí is a founding affiliate. We're hoping that this will be an interactive panel discussion this evening. So with that, I am going to invite Aiste to turn on her camera and introduce herself. Hi, Aiste. You're very welcome.
Hi, Annie.
Thank you so much for joining us this evening here in Galway from, I know you're joining us from sunnier climes, so thank you for that. And I'm going to hand over to your capable hands now to take it from there. So thank you very much.
Thank you very much. Thank you very much, Annie. Thank you.
Actually, sorry, I've just one thing. I actually forgot one job I was supposed to actually do and I've not done. Just to explain to the audience that over the course of the evening, we have received quite a lot of questions in advance. So we have covered a lot probably of your questions from questions that were submitted in advance. But please feel free to use the Q&A function at the bottom of your screen. If you want to post your specific questions for the panel in there, and if you have any comments or anything, please put them in the chat function. And we'll be keeping an eye on that. And there is a team of my colleagues from Croí working in the background to answer questions and queries. So thank you, Aiste. Leave it to you.
Thank you very much, Annie. So hello and welcome everyone for today's webinar on living well with heart failure. So as Annie mentioned, my name is Aiste Streite and I'm the chair of Global Heart Hub Heart Failure Patient Council. I am a patient myself and have been diagnosed with heart failure right before my 30th birthday. It has been 6 years now, and I went through every single stage of heart failure, from the medication treatment in the first couple of years of diagnosis until living with a left ventricle assistant device, it's artificial heart, as we can say, for about 3 years. And now, nearly 1 year ago, I received a heart transplant. My focus as a patient was to do everything in my power to take care of myself and manage my disease. And I really can say that I was living as well as possible with my heart failure during my journey. I as well became a patient advocate since the diagnosis, because I just felt that urge to share my story and raise the awareness about the importance of health at any age, raise the awareness about heart failure, and finally, as I like to say, breaking the standards about living with a disease. I use my story as well and experience to inspire and motivate others to become an educated and responsible patient who is living well with heart failure and could be living with other diseases as well. So I am delighted to be hosting today's important Q&A session on living well with heart failure. So let's get started. And I would like to invite the three panelists we have today. I would like to welcome Ian, Emer, and John. Please, you can turn your cameras on and you can turn your microphones on. Thank you very much for joining us today, all of you across the island who have logged on. And we have a lot of questions actually submitted in advance. And I also welcome your questions live with Q&A function. And I will do my best to bring as many questions to our panel and for the discussion for the next hour. And before we jump into the questions, I would like to ask Ian to tell his story briefly, to introduce himself, to tell about the story of his diagnosis and how you were diagnosed and how you are right now. So please, Ian.
Thanks, Aisha. Yeah, I'm Ian Burnett. I live in Carlow. I'm currently living with heart failure. I was diagnosed with heart failure in October 2018 when I was 38 years of age. Up to that point, I had been living a fairly healthy, normal life. In around the May of that year, I started to suffer from some of the symptoms of heart failure. When I was lying down, I would get a crackling noise and sensation when I was lying down. I didn't have a lot of other telltale signs. I didn't have any swelling in the ankles or in the stomach. I wasn't retaining fluid. So at that point, I just started to go to the doctor just because of the symptoms, because of the crackling noise and having trouble sleeping and waking up. And unfortunately, a couple of times I went to the GPs, and as I say, because I wasn't showing the classic symptoms, I was never tested for heart failure. It was only coming towards my diagnosis one evening, I went to the after hours doctor surgery, and again, because I was waking up from my sleep with my heart pounding out my chest, and he examined me and told me I was suffering from anxiety. And I actually stood there in disbelief looking at him and said, no, there's something wrong with me. And he said, no, that's all there is. So I came home that evening, and it reached the climax to me. I broke down in front of my wife and he said, they all think I'm mad. I said, I know there's something wrong with me. I said, but they're just telling me I have built up acid, indigestion, stuff like allergies, stuff like that. And I said, no, there's something wrong with me. So that following Monday morning, then I went into a walk-in surgery to a doctor, and I was feeling pretty ill, pretty bad at this stage. And she took one look at me and said, oh my God, what's wrong with you? So again, I explained my situation to her. The first thing she asked me was, has anyone done an ECG in you? My answer was, nobody's done anything on me. They took my blood pressure, maybe. That was about it. I didn't have any other examinations. So she brought me in straight away for an ECG, and wrote me out a letter then to go straight down to the emergency department at Kilkenny Hospital. So I proceeded. I got my wife to bring me down there, went in, number of different examinations. They said they were keeping me overnight. A lot of people don't like hospitals, but I was the most relieved man in Ireland at that night. I knew there was something wrong with me. I needed an answer, and I finally felt that somebody was listening to me. So they kept me in there that night, a number of different examinations, echo examinations, doing bits and pieces. So they moved me then from off the ward into the CCU. So I spent almost a week in the CCU in St. Luke's Hospital in Kilkenny. I was admitted on the Monday night, and on the Friday night, I suffered a stroke. So thankfully, I was in the hospital, in the ward. They responded quickly. Within 25 minutes, I was treated and back down in the ward. And thankfully, I've made a full recovery. I have no after effects from the stroke. So that was on the Friday. Then on the Monday, my condition wasn't getting any better. They moved me by ambulance from Kilkenny Hospital up to the Mater Hospital in Dublin. I thought Lewis Hamilton was driving down, and so I was up there in about 30 minutes. Couldn't believe it, up through Dublin traffic and all. They took me in again, absolutely fantastic. I was brought up at the time. They were doing up their CCU unit. They were using this different unit. I had a private bed in a private room, Croí Park out through the window, television. It was like being in a 4-star hotel more than a hospital. And I have to say, the treatment I got there was absolutely fantastic. The most important bit of information that one of the doctors gave to me up there was, whatever you do, says, do not Google it. He said, you'd have yourself dead in the morning if you Google it. And I never have. 3 years, 3.5 years there. It's something I won't do. I refuse. I'm in the doctor's hands. I'm in the medical professional's hands. I'm not going to go down that road. So I suppose I was in there, and again on a Monday I was admitted. And that Saturday then I took another small mini stroke, a TIA. Again, responded to quickly, treatment, back up in the room. Luckily enough, again, I don't have any side effects from the stroke. Treated well, kept in for 4 weeks in the Mater while they were getting my tablets and stuff right. And then eventually, excuse me. I don't know why you get like this now, sorry.
You're okay.
Sorry, it's the first time I really told my story.
It's okay. Take your time. I actually, being a young patient, I can really relate to what you're saying. And to be honest, I was surprised when you said the crackling thing, because that was exactly the first kind of symptom that I felt right way before my diagnosis, and I couldn't even explain into the words, as being a young person who never ever heard about the heart failure. Like,
Yeah.
how do I explain it to the doctors? Like, and I used to say, is that when I lay down and I take deep breath, it just feels like somebody's pressing these bubbles into my chest. Like I couldn't even explain it properly. But I can relate to so many things that you have said, and your story is absolutely amazing, what you've been through and how strong you are holding. And I really appreciate that today you're sharing your story with us. But I think the most important question that I would like to ask for you right now is, like, how are you feeling today?
At the moment, besides the last few months was a bit emotional, I've been fantastic. Unlike you, I'm probably not behaving as I should be. I should be taking care of myself a little bit better. I'm having a lot of irregular heartbeats at the moment. What I was trying to say was, before they discharged me from hospital, to put the ICD in. So I'm constantly being monitored for that. So I'm getting a lot of irregular heartbeats at the moment. So I'm waiting for treatment on that. And through that, I'm afraid to do any exercise, to exert myself in any way. I'm afraid of getting a shock from the ICD. Really, I don't know what's going to happen from that. So I'm trying to see. I'm seeing the specialist up in the matter at the moment, for the electrical side. So hopefully something will happen with that soon enough. But other than that, I'm great. When I was admitted to Kilkenny Hospital, my heart function was between 10 and 15%. When I heard that, I was actually amazed. One of the consultants said to me, I probably had 24 to 48 hours left in me. I was going down, I was deteriorating fast. I thought it was 10 to 15% of 100%. So that was quite scary. It was only afterwards then I learned 55 to 70% is the normal healthy range. And now, thankfully, I'm up to around 30%. And I'm doing really well on that. Again, a consultant said to me, you could be at 40% and have really bad effects. Each person is different. Don't get fixated on the numbers. It's how you're feeling. That's the most important thing. And at the moment, my life doesn't change. Okay, I behave a little better. I was never into drugs. I was never really into drink or anything like that. So that doesn't affect me. I'd have an odd drink, but I wouldn't go out and get drunk. I'd have 2, maybe 3 drinks. Excuse me. Nothing over the top like that. But other than that, my life is as normal. I can carry on and do what I was doing beforehand, thankfully.
Absolutely. I'm glad to hear you're doing well. So please keep up that great work, and take care of yourself, because that's the most important thing. And jumping into the questions, actually, I would like for John actually to explain the term of heart failure and to talk about heart failure. What actually does it mean? And it is a very frightening term to hear for the first time. And Ian has highlighted that, when you hear that you have a heart failure, you actually really think that your heart is completely failing, that you won't be living, you might die very quickly. And maybe John, you can highlight the points of what the heart failure is and why is it called the heart failure. Thank you, John.
Yeah, I suppose, Ian, thank you so much for your telling us your story. And I'm unsure, just from what you said, would the doctors in the matter and the Kilkenny say what the cause of your heart failure was?
Yeah, at the time, they were putting it down to a virus.
Yeah.
So I went in through further investigations and I attended the Heart House in the matter, and they'd done a gene testing. So I tested positive for this Titan gene.
Oh.
So they reckon it was genetic, that I always had this heart failure in my system, but the virus brought it on then.
Okay. So I mean, heart failure, it might be an idea to show the heart. I have a little model of the heart here. I use this in my clinic in Galway University. And now I wouldn't say, Ian, that I call myself an expert, you know. I mean, Ashta, thank you very much for referring to me, or somebody referred like that. I'm a physician cardiologist. I've been running a heart failure clinic in Portiuncula Hospital in Ballinasloe before I semi-retired. And now I'm looking after the heart failure clinic at University Hospital Galway. So I have a lot of experience in managing patients with heart failure. And I find that a picture paints 1,000 words. I mean, you can try read stuff, but it's not good enough. I mean, the heart, for those, I hope that's showing up relatively well. It's got 4 chambers, you know, and there are two top chambers here, which are reservoir chambers. And then you have 2 bottom chambers here. And this one here is the left ventricle. And you can see the muscle. It's not the greatest model, but this is the muscle of the heart. This is the pumping chamber, the main pumping chamber of your heart. On the right side is another pumping chamber, maybe not showing terribly clear. It's the smaller pumping chamber just here. And that chamber pumps, the only organ that pumps to is your lungs. And this pump, the left ventricle, pumps to all the other organs in the body. And therefore it's a bigger pump, and there's a higher pressure system in it. Now, heart failure is a syndrome, which is manifested by usually symptoms. Patients would have symptoms which would indicate to us as either nurses or doctors or health professionals that this patient may have heart failure. All right. And there's many causes for heart failure, and Ian obviously has a particular cause, which happens to be a genetic problem related to this titin protein. And it's not an uncommon one in terms of genetics. So if one has the commonest cause of heart failure, I'll just put on the front of the heart here now, if you don't mind, just to show you this. We can see that it's not a great model, but it shows some vessels coming down the front of the heart here. And these vessels coming down the back and the sides, you can see the vessels here. These are supplying the heart muscle. And these are the coronary arteries. And if you get blocked coronary arteries that become blocked, and if they become blocked suddenly, it causes a heart attack, because these arteries are supplying this muscle. And if the arteries get blocked suddenly, then you get death of the muscle. And this can result in scarred heart. Now, and this would be maybe a cause of heart failure if the damage is sufficiently large. But there's other different causes. There are conditions which just affect the muscle on its own, that the arteries are okay. And this is called cardiomyopathy, a disorder that affects the muscle of the heart, that makes the muscle weak. And so the muscle doesn't pump properly. And Ian has a form of that, a cardiomyopathy, which is just a disorder of the muscle. I expect Ian probably had an angiogram which showed that his arteries were okay, I suspect. That may be, Ian, that may be so.
Yeah, that's correct. I had the angiogram and all my vessels, everything was fully clear, all the arteries were clear.
So all Ian's arteries, these things running over the surface of the heart muscle, were normal. So heart failure is a syndrome which is usually associated with symptoms. And then when the patient is examined, you may find what we call the signs of heart failure. You may find swelling on the legs. You may find prominent veins in the neck, because the veins from our head and our arms come down into the heart, into the right side of the heart, and then there's veins coming down into the left side of the heart here. So you can get prominent veins in the neck as one of the signs that will tell us that maybe there's a problem with the heart. And then by listening to the heart with the stethoscope, we can also hear some signs that the heart is under pressure or under strain. So it's a combination of just having symptoms, and then for the doctors or nurses examining the patient, you'll find that they may have signs. So that's, Ash, I hope that sort of explains a heart failure. And there is, the two types of heart failure. There's the heart failure with what we call reduced ejection fraction. Ian mentioned mentioned this 10 to 15% that he had. This is something called, the doctors and the technicians who do the echo scans, the heart ultrasound scans, refer to ejection fraction. It's a measure of the squeezing function of the heart, okay? And the normal ejection fraction. And I often ask my patients, Ashta, and it bothers me that when patients come into the heart failure clinic and ask, do you know what ejection fraction is? And the vast majority of them do not know. And the ejection fraction, and there's an educational problem, there's no doubt about that. But the normal ejection fraction is 55% or greater. And this is what Ian was referring to. His ejection fraction was 10 to 15%. It's not 10 to 15% of 100. That's very important. But still in all, Ian had a very low ejection fraction. There's no doubt about that. And it's good that it has increased with medication, I think, up to around 30%, and there may be some improvement. The other form of heart failure is maybe one that we see in older individuals who've had risk factors, such as high blood pressure, diabetes mellitus, who are obese maybe, who have lung disease or may have kidney disease. And this is heart failure with preserved ejection fraction. So you can have a heart failure where the ejection fraction, the squeezing, we measure the squeezing and the squeezing is normal. But despite the fact that the heart squeezes normally, you have heart failure with preserved ejection fraction. And this is something, as I say, that it will occur in patients who have multiple risk factors, who may have rhythm disturbances in the heart called atrial fibrillation, typically high blood pressure, kidney problems, diabetes mellitus. So the heart, not only does the heart squeeze, the heart would squeeze the blood out into the body and around the organs, but the heart has to relax to let blood in. So the blood is coming in from the lungs into the main pumping chamber here through these red veins. You can see them there in the top chamber. The blood is coming in through the valve into this pumping chamber, and that pumping chamber has to relax to let the blood in. And if the relaxation ability of the heart is impaired, you can then develop symptoms of heart failure as well. So there's two types in a way, the two types of heart failure, the heart failure with reduced ejection fraction and the heart failure with preserved ejection fraction. And we are seeing more and more patients with what we call heart failure with preserved ejection fraction, where the muscle is apparently squeezing normally, but yet the patient has symptoms. I hope that sort of satisfactorily explains.
Absolutely. Absolutely, John. Yes, it is understandable, and it's even greater to see the heart and to see visually, where is what. So it's very helpful. Thank you for bringing the heart to this discussion as well. I would like to ask and include actually Emre to comment on this question. Do you think, from your experience, what are the patient's biggest fears on diagnosis? Can you share your day-to-day experience on this?
Sure. Thank you, Ashta, and thank you, Ian, for your story. It's very compelling. And really, I guess Ian mentioned the term heart failure is a very frightening diagnosis. For many patients, they feel that when they're told that they have heart failure, that their heart is about to stop or they're about to die, as you mentioned, Aisha. And you wonder, will you ever live a normal life again? Can there be life after this diagnosis? And I hope that from tonight, people will learn that there indeed can, and you look at yourself and Ian as living examples of that. The fear is a big thing, and the fear and uncertainty, the lack of understanding, I suppose, like Dr. Barton there just explained about what heart failure is. And I suppose heart failure does not mean that your heart has failed or that your heart is about to stop. What it means essentially is that there is a problem with the heart supplying blood to the body, either due to a pumping problem or a filling problem, as Dr. Barton just explained. And really, when I meet a heart failure patient for the first time when they're diagnosed, I'm very reticent to introduce myself as a heart failure nurse. I come in and say, I'm a heart specialist nurse, and I'm here to help you understand your condition, to teach you how you can live well with it. And I only introduce the term heart failure at the end of my conversation. because by that time the patient has a good kind of handle of what they're actually dealing with. So I think that's really important, to focus on the positives, that people can live well, that there is treatment, and with good education and treatment, people can go on to live very well with this condition.
Thank you. And as well with the managing the condition, you know, it all leads to the better quality life. So I totally agree with you. Thank you very much for this. So moving forward, we have a question from the audience saying, okay, I have a diagnosis. What do I do now? How do I manage my heart failure? And I would like to dedicate this question to John and Emma. So can you please comment on that? What do I do next?
Will I go, Emer?
You can start, yeah, go ahead.
Thank you, Emer.
Thank you.
And so what we have to do as healthcare professionals is to decide which type of heart failure does the patient have. Is it the patient who's got the reduced ejection fraction, where the pump is not squeezing well, such as in Ian's case, or is it a patient who has the preserved ejection fraction, where the pumps seem to be squeezing well, but there's a problem with, let's say, relaxation of the heart muscle? Fortunately, maybe over the past 30, 40 years, there have been medications which have been developed and are available, which can significantly help the patient who's got the heart failure with reduced ejection fraction. I've no doubt Ian is on some of these medications already. And there's been really significant breakthroughs in the last 6 or 7 years in terms of the medications that can be used to treat that heart failure with reduced ejection fraction. It does depend to some degree on what the cause of the heart failure with reduced ejection fraction is. And still one of the commonest causes, at least in the Western world, is where people have blocked arteries and they've had heart attacks and scarred heart because of blocked arteries. And that has to be dealt with separately, such as with stenting or bypass surgery. But outside of that, then you have the medications which are specifically used to try and help the pumping function, to improve the function of that left ventricle or the right ventricle in its pumping function, improve the ejection fraction. So there are very good medications for that. And for the other type of heart failure, which is the heart failure with preserved ejection fraction, where the pump is apparently squeezing well, but not relaxing very well, there's a lot of conditions associated with that, such as chronic obstructive lung disease, high blood pressure, diabetes, kidney problems, and one has to address those problems and treat those conditions to try and help improve the heart failure with preserved ejection fraction. And the main medicine for the heart failure with preserved ejection fraction, where the heart is pumping okay, but there's fluid in the chest or there's fluid in the legs, is the diuretic medicine. Ian may be on some diuretic medicines, water tablets, we call them, which make you pass out salt and water through your kidneys. And there has been a breakthrough more recently, Ashta, with heart failure with preserved ejection fraction. A drug that was introduced for diabetes maybe 15 years ago has now been found to be beneficial for patients who have heart failure with preserved ejection fraction. So there's always breakthroughs coming in terms of management and treatment. And if drugs are not helping or improving things for patients, then you have what we call devices or special pacemakers or defibrillators. Ian has a defibrillator now, I understand. So there's an awful lot of treatments that can be, drug treatments that can be provided. But outside of the drug treatments, maybe Emer would like to talk about some of those other things that can be done to help the patient in respect of their symptoms of heart failure.
Yes, absolutely, Dr. Barton. And I suppose Aisha and Ian would very much remember that kind of feeling of lack of control, maybe over what's happening to them. And self-management is all about taking control. And to get that education to begin with from your heart failure nurse specialist or your healthcare team about how you go about that. So it's about understanding what the signs and symptoms of heart failure are. So they include breathlessness, swollen legs, and fatigue. And then you have some more symptoms like what Ian described, which is waking at night, gasping for air, a cough with frothy sputum, the other kind of symptoms, that they're the main ones. So exertional, a reduction in your exercise capacity. So you're not able to do as much as you normally could. You notice that you get breathless, you get tired, that you need to stop to take a rest, that you're awfully tired, low in energy. They're the signs and symptoms to watch out for. Then weight monitoring is something that we teach patients. Because the heart is not pumping blood around the body, fluid tends to accumulate, and that accumulation of fluid can be caught very early by the patient themselves if they're taught how to weigh themselves. So we would advise daily weights first thing in the morning when you get up after passing water, standing on the scales in your night clothes to note your weight in kilograms. And a kilo is equal to 1 litre of fluid. So we need to know what our dry weight is, what our weight is without fluid, and then we go by, if in a week, in the course of 7 days, your weight increases suddenly by 2 kilos or more, that is a sign that you may be retaining fluid if you've got heart failure. So that's another thing that patients can self-manage and record. They can keep a little eye on their blood pressure. There is lots of technology now, apps and smartwatches and whatnot. So the other things then in terms of your lifestyle would be to eat a low salt diet. And if you're advised by your healthcare professional to restrict your fluids, fluid intake, obviously we're trying to manage fluids. So that's another thing that a patient can do. And then for the patient to know who to contact in the event that they notice more symptoms. So to have a point of contact, be that their GP or their heart failure service, that early contact for deteriorating symptoms can stop a potential hospitalization or the patient getting worse. So it's to kind of teach the skills to the patient to manage their condition and take control. And I don't know whether Aisha and Ian, would you say that it was difficult for you to learn those skills or to implement them and to motivate yourselves to keep doing that? I know Ian mentioned that sometimes he behaves better than other times. So what would you say about that, Ian? How easy is it to implement those self-management skills in your day-to-day life?
Well, I suppose if you put a bit of effort, it's not too difficult.
Yeah.
There's another there's a participant on it, Kira, from Centric Health. So they have an app out now, and they contact me twice a week. So I send in my blood pressure, weight, mood feeling, how I'm feeling. Like that's constantly monitored twice a week by them. So they make sure that I am doing it through that. So that's a good way of having it. It's a great service to have.
Yes, telemonitoring is becoming more popular. There is also an app, I'd like to mention the Fluid Heart Tracker app, which is the creation of one of my colleagues, Norma Caples, down in Waterford, and it's free to download on the Apple Store and on the on Android Play Store as well. It's a little app that you can use to monitor your weight, and it will alert you if your weight rises by 2 kilos in 7 days. So it's an app that's endorsed by the Heart Foundation as well. So there's lots of useful little tips and tricks that you can use to help you manage your condition.
That's amazing. And actually, you know, all these tips are very valuable, and I don't think they are very hard to actually apply on a day-to-day. It's just that you need to kind of dedicate your time and, you know, be that informed patient and really take care of your health. And I love that, you know, I had multiple questions already prepared, and through your answers, you actually answered those questions, highlighting the importance who to contact when you feel the worsening, highlighting if medication doesn't work, what is next for me, and then as well highlighting the ejection fraction reduction and, you know, what are the next steps. So I would like to ask Ian actually one question, and maybe John and Emma could add a comment on it. There is one question saying, I'm on so many medication, and how do I manage them all? Ian, did you find a best way for yourself how to manage taking so many medication during your heart failure journey?
So yeah, one of the biggest problems I really had, like we touched earlier on, was your fluid restrictions. So when I was in the hospital, I had to take a number of different tablets, and at the time I wasn't very good at taking tablets. So with each tablet, I was taking on quite a bit of water. So while I was taking my tablets, I was using up most of my allowance on a day. So now it's one mouthful, everything in and down in one go. The driver just said that's the best, works the best for me. But there's definitely a lot of medication in it, yeah.
And Mer, do you have any suggestions or comments?
I just want to make the point, absolutely, fluid restriction is not relevant to every patient. So for the likes of Ian, it may be very important. But patients that have mild heart failure with no symptoms of swelling may not need to restrict their fluids. So the evidence, so for those that do, I guess it's to maybe measure out their fluid, you know, if it's a lot of tea, coffee, water that you're drinking, to use maybe a measuring jug at the start of the day with your 2 liters in it, and to just make, you know, be very selfish, make your tea from, you know, nobody else is getting a cup. Use the jug so you can keep an eye on your fluid volumes. If you're very thirsty, watery fruits like oranges, melons, pineapples, and you know, even ice lollies are very low volume, about 35 mils of liquid. Ice chips and taking water into, you know, rinse in your mouth, or mouth rinses are also very helpful for anybody that is on a fluid restriction and finding it difficult.
Thank you very much. That's amazing. John, do you have a recommendation possibly from your side?
Well, I suppose if you look from my perspective, if you look at the research, let's say, on fluid restriction, it's very specific for people who've got, you know, tremendous amounts of fluid and overload, what we call overload, and swelling on legs and quite symptomatic, and it nearly has, correct me if I'm wrong here now, Emer, but
no.
It may be particularly valuable if a patient's in hospital and there's a lot of symptoms related to heart failure. And I have a feeling that maybe we don't sufficiently emphasize that the salt issue as much, Ashna. And I don't know, maybe in your own country, but we have a major deficiency in dietetic advice and guidance for patients, at least in our clinic. I don't know what it's like elsewhere in Ireland. But in terms of, you know, discussing salt, okay, because when we give the water tablet, Lasix or Frusemide or Burenex, which is bumetanide, that's actually, the way those work is to get salt out through your kidneys. So it makes the kidneys pass away salt, and with the salt, of course, goes the water. So if you're taking a high salt diet, you're really counteracting, you know, you're counteracting your diuretic medicine. So there is a whole issue around salt, and I think there should be a little bit more focus on it to a degree, certainly, you know. And so the salt and the fluid issue is certainly relevant, but may not be the most important thing. And patients obviously observing their weight and taking their weight, and maybe some people will have blood pressure machines at home and things like that. You can do that, and there's a lot of app work now going on which will monitor blood pressure. I think Ian has mentioned your own, whether you're monitoring your blood pressure at home as well. Is that right, Ian?
That's right, yeah.
Yeah. So and your weight as well, and all those things can be very helpful in terms of the nurses or the doctors managing you, or managing the patients who have heart failure. I'm not sure if that's a sort of a helpful comment or not. I don't get enormously fixated on fluid or salt necessarily, unless patients are really very, very markedly volume overloaded and are very symptomatic, where that's the patient who really does benefit from a salt and water assessment and having been seen by the nurse or the dietitian to advise and guide them.
Perfect.
Taking the medications, and of course the problem, we all know this, Ashta, compliance with medications isn't easy. People miss medicines and they're not terribly compliant. Oh God, I forget the one in the evening. I take it in the morning. I'm busy. And maybe having the Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday little box, and the morning and afternoon. You'll see these available for people who they've got 10 bottles on the table and take a tablet here. It's not so easy, and yet the medicine is extremely important. It's really very, very important that patients take their medicine. And we know, God knows, it's not easy taking medicines. Given my age, I'm even taking some myself, but you have to be religious about it, I think. And it's particularly important in patients with heart failure with reduced ejection fraction.
Absolutely, John. I couldn't agree more. Being myself a patient and kind of going through different phases of heart failure, living with like artificial heart, and then being a transplant patient. I had been using and taking a lot of medication, and I really found that it helped me to have a pill box, and as well just in case to set the reminders even on the phone or even on the calendar, just to make sure that there is a time and I take my medication, and I always was compliant with my medication and adherent, and I always take my medication on time. Probably during the 6 years, I probably missed to take a medication maybe like 3 times or something. So it's really low number, but that's what really helped to control my heart failure, because I was so dedicated to take this medication and, just control it in general, kind of built my heart failure back again, whilst being on artificial heart and now being with a transplant. I have no choice. I have to take my medication every 12 hours. There's no other question. So thank you very much for that. I think that was very, very useful. But there is one more question as well that I would like to ask actually all of you on the panel today. It's a question about the sexual relationships and intimacy. This is a very important question. And I know from my experience as well, and working along together with the patients, they really are shy to ask and to discuss that with the specialists. And, some of the patients are saying that, if someone in a relationship is diagnosed with heart failure, the intimacy is changing after the diagnosis, and they have questions such as, is it safe to have the intimate relationship? So I would like to, ask all of you to get involved in this discussion and give your views on this.
I don't mind starting on that one if you want. I suppose fear, there's a lot of fear around an increased awareness of your body and changes in your heartbeat and breathing, and fear to resume sexual activity after any kind of cardiac diagnosis is very common. And as Aisha said, people are embarrassed to discuss it, and they shouldn't be, because it's part of normal daily life and it's an important part of living well. So with mild heart failure, with a person who has mild symptoms or no symptoms, it is safe to have sex. If, however, the patient might be, if you have severe breathlessness or volume overload, it might be best to hold off until your condition is a little bit more stable. Also, if you can engage in moderate exercise, if you can climb the stairs without breathlessness, if you can engage in brisk walking, there's no reason why you can't have a normal sex life. And what I would say as well is that you can have a very low sex drive as well. And that can be very common in patients with cardiovascular disease, and it can be linked to anxiety and depression, be that around their illness or the impacts of a new diagnosis. So be very careful to watch out for signs of depression. Talk to your GP. There is help for that. There is counselling. Communication with your partner, both ways. Be very open and honest with each other about how you're feeling, what your fears are, because that can go a long way to creating intimacy as well. And just for the men as well, to raise the issue of erectile dysfunction, which is common in cardiovascular disease. So there might be patients out there who are wondering, can I take drugs like Viagra, for instance? That would be the most common one that everyone knows. I suppose talk to your GP. There are certain medications that cardiac patients could be on that are absolutely not ideal to, you should not take Viagra with nitrate medications, which would be for patients with coronary artery disease. They might be on nitrates such as Imdur or isosorbide mononitrate or glycerol trinitrate. There's different types of formulations, so always check with your GP before using those drugs and to see what's suitable for you. Is there anything else you'd add, Dr. B?
Well, I think one of the important things to mention here about exercise is that for people who have heart failure, exercise is beneficial. There's now sufficient research to show that the patients who are fit, relatively fit, do better. Okay, so it's a little bit like if you're exercising your muscles, the muscles in your body, your legs, your arms, etc., you're making those more efficient in terms of using oxygen. And if you make the muscles in your body more efficient in terms of using oxygen, that's less pressure on your heart. And if you have a failing heart in any form, that's beneficial for the heart. So exercise is actually good for the heart. And it is also good for patients with heart failure. Now, obviously, there are limitations to what one should do and shouldn't do. And funny enough, the European Society of Cardiology has just produced expert paper in the last year, I think, on sort of exercise in heart conditions. I'm only getting my head around it now, but it's a useful document. I'm not sure if there's a shortened type version which may be of value to patients, and there may be. I see some of the sites coming through there from Annie and others. So that may be very helpful. And I think that's a very important point to make, that exercise is beneficial. Now, I don't mean going into a gym and lifting the weights or something. No, we all know that the common prescription in terms of exercise is 30 minutes a day, 5 days a week. A brisk walking to get yourself sort of warm across your brow is a sort of an indication that you're exercising well. I think, Ashta, I don't know about other nations and other countries. Ireland has an issue around sex and talking about it. And even I, as a physician, cardiologist, wouldn't specifically be necessarily asking patients, and yet I think it is something that we should be asking patients. Look, are you having any problems with the intimacy or sexual issues? I just think that we have a really significant deficiency, at least in the Irish context. That's just my personal opinion. Would I like to have somebody, a psychologist who has an interest in that area, who would be attached to clinics and helping patients who have heart failure in respect of this? I absolutely would. And I think it's a big deficiency, at least within our system, and I don't know what it's like in other nations. And I think it's so important, because sexual health is so important. It's part of all of our lives, and there isn't enough focus on it at all, Ashton. I suspect that's why you maybe raised the question. I don't know, but
absolutely. No, absolutely. It's a very important question, and it's not discussed openly, which it should be, because it's a major impact for a patient's quality of life. Ian, do you have anything to add on the comments from the doctors?
I suppose initially there was a bit of caution after my initial diagnosis, but as time goes along, everything's just returned to normal. So I have no issue there. Thank you.
I know I had to, from my team, come in that, when you can freely walk 1 kilometer without shortness of breath, you're good to go. So I think that's as well with your comments and your recommendations. It's a good point to pay attention to. And if something, of course, always consult with your specialists, with your doctors. I would like to jump into probably the most important part of the questions that we have. Which were raised. It's about the heart failure being a frightening diagnosis, and is there a hope for me to live a normal life after that? Like, what do I need to do to help myself live with heart failure? And I would like to, for you, all of you right now, just to highlight the points on importance of the emotional health, empowering patients to share their stories, power of the community and peer-to-peer support, self-care and their education. So please, could I start maybe with John to say, how do I live a normal life? Is there a hope?
Yeah, and I do this. I think one of the clinics in the Irish context who changed the name of their clinic. They took away the heart failure clinic. They took away the name. I can't remember what name they made it. Emer, you might know, but
heart deficiency clinic, is it?
Oh, maybe
or heart support,
like
maybe something like that. Yeah.
Look, there's no doubt that word, that concept is saying, oh my God, what's the outlook for me? And it's worrisome, and there's no doubt about that. And I do think there's a psychological component to it. We recently, at least here in the HSE West, now have a clinical psychologist who is now helping us with patients, which is very, very useful and can be very useful. And I think, again, it's another area that's not really sufficiently addressed, I think, by physicians. I don't think it's sufficiently well addressed. All sort of forms of heart disease, people who've had heart attacks and people who've had valve replacements, etc. There's a psychological impact of any disease or condition on the mind. And I don't think that it is sufficiently well addressed. But I think there's a greater move now towards developing psychologists who are going to look after patients who have cardiac conditions and deal with the psychological impacts of disease on mental health. And I think we're not nearly as good as we need to be, but one can only hope that for the future that things will improve, Ashta. So maybe I'm not sure if that's a sufficient comment. I think it's a very important area. And I think that the nurses and patients who go to cardiac rehabilitation programs, and indeed maybe many of our heart failure patients should enter cardiac rehab programs in some shape or form. And that rehab programs, you may very well have attached to a rehab program a psychologist who helps patients cope or deal with that diagnosis. But I'd be inclined to be, it's the glass half full, Ashta, rather than a glass half empty. The treatments for heart failure are so much better than they were. I mean, when I started training as a young doctor and when I was an intern, and for those patients who are listening who may have heart failure with reduced ejection fraction, beta blockers, which are now one of the cornerstones of heart failure, I suspect Ian may be on a beta blocker, were contraindicated in heart failure. Contraindicated. And now they're a cornerstone of heart failure management. So there's been huge breakthroughs, huge improvements in treatment. And so I think people do not necessarily have to be, yes, it's a worrying diagnosis, and it can be associated with the worst prognosis. There's no doubt about that, but things are improving really dramatically. And you now have devices which are also helping the lot for patients, and defibrillators, and Ian has one of those, and the defibrillators are there to help prevent sudden death. So you have all these supports and medications, and then now devices. And listen, it's improving all the time. There's no question.
It's moving forward very quickly. Emer, would you like to comment and give your perspective and maybe recommendations?
Yeah, peer-to-peer support, I guess I'll just pick up on that point that you made, Aisha. Peer-to-peer support is so important. Like, it's so lovely to see yourself and Ian here today again, living your best lives that you can, given your diagnosis. It's not you're not held back, you're out here doing your best and moving forward. And that's all you can do with a diagnosis of any diagnosis, is move forward. We can't look back. We can just deal with what's in front of us now and how you can take control. So I'd just like to point out that there's a really good resource for patients called the Living Well program that the Health Service Executive run, and the links for that will be put up in the chat. And it's basically a national program that's delivered across across Ireland. It's free. It's 2.5 hours per week, online at the moment, but they will be going back to face, and it's peer delivered. So it's a really, really good program that will teach you the skills that you need to motivate yourself and empower yourself to take control of your condition. It's great for addressing things like the isolation that you might feel, and you know that you're not the only one that's walking in these shoes. There are others like you, and you get so much from talking to other patients. Health professionals can only do so much, you know, but we're not the ones living this. You are. So I think that peer-to-peer support is fabulous. And I would recommend anybody living with heart failure or any chronic disease. The Living Well program is for any chronic disease, such as asthma, COPD, arthritis, whatever. You know, it's a really good program. So consider looking into it. It would really be a good thing for you.
Absolutely. Thank you very much. Ian, would you like to add something? Maybe you have any tips or, you know, strategies or how to really help yourself as a patient?
No real tips, I suppose. I was very grateful to have the services of somebody like Emer, a heart failure nurse, to constantly call on any day of the week. I could pick up the phone, call. If she wasn't available, there was an answer machine. She'd get back to me. She'd reassure me about anything. But the biggest thing I try to do in my life is don't get stressed. Stress brings on a lot of problems itself. I'm not qualified or anything like John or Emer there, but I try to avoid stress at all possible. I let things slide if I have to let things slide. I don't worry about the small stuff.
Absolutely.
Unfortunately, there's not a lot we can do. We can change. We're taking our medication. We're looking after ourselves as good as we can, and we just have to trust from there.
Absolutely. Thank you very much. We actually have a few more minutes, and I would like to jump into questions that we received into our chat. So actually touching to the last point that Ian mentioned about the stress, and there is a question regarding that. How much does the stress affect the person in a heart failure if the stress is not addressed? So maybe John and Mary could comment on that.
Go ahead, Emer.
Thank you. Well, stress releases hormones, the fight or flight hormones, and those hormones are actually a lot of the, if we were to look at what causes heart failure, it's those kind of stress hormones. Now, not to say stress causes heart failure, but when heart failure happens, when the heart is not working properly, the body releases these stress hormones. So if you're actually stressed on top of that, you're going to put out a lot more of these hormones, and they have negative effects in the heart for sure. So I think it would be important to access support if you feel that stress is really taking over your life. You know, there's loads of good support out there. There's Minding Your Wellbeing, again, another HSE program. There's the stress control program. Talk to your GP. You know, there's lots of resources out there for you. Mindfulness, exercise. You know, it is important to try and address and curtail, cut out whatever. Like Ian says, he doesn't sweat the small stuff. If there is things in your life that are particularly causing you stress, maybe you need to address that. Is there anything you can eliminate in terms of stressors? And if you can't eliminate them, how can you teach yourself to kind of cope and get the coping skills to kind of deal with that a little bit better? Yeah, but there is loads of programs for stress management, and definitely if that's a big part of your life that's really affecting you, I would advise you to seek help.
Perfect. And John, do you have like a short comment on this?
No, I think Emer has covered definitely most of it. I suppose those stress hormones, they may result or precipitate rhythm disturbance or arrhythmias in patients with heart failure, and some of those rhythm disturbances can really genuinely upset the heart or even the heart function. So we all have stress in our lives, you know, and we have to. It's a matter of how does one cope with it, and I think those. Maybe the online programs, etc., may be very beneficial. And again, of course, the psychologists and having psychologists involved in heart failure services would be very, very useful for people managing or coping with the stress, because, you know, generally we can't avoid it. I think Ian's Ian has it right there. You know, I don't worry about the small things anymore. You know, you don't have to, but we all have stress, and it's how we cope with it. Really, I think is what's important.
Absolutely. I have a few more questions which I really want to touch, and I know we have a few minutes. So maybe two of you can comment any advice regarding the activity where the person has a very limited mobility, what to do in that space.
I can give some advice there. Yeah. Say for a person who might be chairbound, stationary cycling. You can purchase little stationary pedals. Even the supermarkets like Lidl and Aldi sometimes sell them quite cheaply. They can also be used at table level to exercise the arms, and also maybe even just doing some light weights like a can of beans in your arms for a person who's very chairbound. Any activity is important, like Dr. Barton did say, you know, even if it's just get out of the chair and move as much as you can if you're able, and do what you're able within your limits. Try and get walks in if you're able to walk safely. Do move as much as possible. It's to not sit in the chair, because most muscles are going to get very deconditioned, and deconditioned muscles kind of don't help heart failure. So stay active as you're able, and as long as your symptoms are stable. You know, don't listen to your body. Don't overdo things. If your body is, you know, if you're breathless, if you've got chest pain, if you're lightheaded, you need to slow down, sit, rest a while, and pace yourself as well. For somebody who's not very active, pacing is really important, and energy conservation, because of the effects of fatigue. So just little bits. If you need to shower, for instance, sit down, rest a while afterwards. Don't pursue another activity that's going to take a lot of energy immediately after. Pacing is important.
Perfect. I actually have a question for John, and that's the question which really I wondered as a patient. Is it okay to be around the other people who are smoking?
Oh, wow. It's a really good question. You know, and what we know is that passive smoking is not good, and this was one of the reasons why, at least in the Irish context, and I think we may have been one of the first nations in the world to ban smoking in pubs, because it's bad for your lungs. But passive smoking is not good for the arteries in your heart. I mean, that's the main thing, not good for the arteries. So if you have blocked arteries, then passive smoking isn't good and to be discouraged, or inhaling passive smoke is not a good thing. For patients who have heart failure with reduced ejection fraction, who maybe it's a cardiomyopathy, I'm not sure that there's any great evidence around that it's necessarily unequivocally bad. But look, in general, the rule of thumb is smoke is bad. It's not good. And it ain't good for the heart, and it ain't good for a whole lot of things, including stomach, kidneys, bladder, everything. It's just I hate cigarettes, I have to say. I know some people are addicted, and it's very difficult. But in terms of passive smoking, yeah, it's best avoided. You know, limited, I suppose. We're all social. We're out socializing, and again, you know, maybe it just can't be avoided in certain circumstances. But I think the thing is to limit it and to avoid it. I don't know if that answers the question or not. I hope it does. But
yeah, absolutely. Thank you very much. And I actually have a last question I would like to ask John as well. Is, can the heart reverse the damage done to it? I think that's a very important question, and every patient actually, I think, you know, kind of hopes that it might actually get better. But what the practice said in your experience?
Yeah, and I think, well, and I think Ian had mentioned already his ejection fraction, so the squeezing of his heart, ejection fraction was 10 to, it's now up at 30%. So that's a sign, yes, particularly in patients who have cardiomyopathy. It's quite common to see an improvement in function of the heart, which is related to how you self-manage yourself, take your medications. So we know these medications work. We absolutely know they work. And we didn't mention, Ashta, there's an awful lot of patients who have what we call asymptomatic left ventricular dysfunction. So that main pumping chamber, so sometimes patients are picked up because they're in hospital for some other reason, and they end up going for an echocardiogram or heart ultrasound, and say, oh, lo and behold, your heart's not working very well, and the patient has no symptoms. So you have asymptomatic left ventricular dysfunction, and we now know that patients who are given the heart failure medication, some of those medications can help prevent the development of symptoms of heart failure and can improve the function of the heart. So there's a lot of stuff going on, but maybe look, the future is going to be genetics and maybe new muscle development for the heart. There's a lot of work going on now, I think. And there's a lot of stuff going to come down the road, and which is going to improve the lot for heart failure patients, without a doubt. Aside, of course, from Ashta, which you had, the left ventricular assist device, and then heart transplantation. But there's going to be more than just those two, I think, in the future. I might not see it, Ashta, but I'm sure some of the younger members looking on here may very well see it. And so there's a lot of hope, I think, for the heart failure community.
Absolutely, it's a great news for everyone in the community. And I would like to close this session, but I would like to ask all the panelists, Ian, Emma, and John, to have the final messages they would like to communicate or to share with the viewers today. Just a short comment or recommendation.
Emer, maybe go.
Yeah, just you can. It's not, you can live well with heart failure. Take back your control. Try and engage in the self-management. Take your medications. Try and do what your best, and that's all you can do. And go try and live your best life. That's what I would say. Yeah.
Perfect. Ian, would you like to comment?
Yeah, pretty much echo what Emer has said. Unfortunately, as John touched on earlier on, the term heart failure is one of the most horrific terms that could be given to something. It's not the be all and end all. You're living proof. I'm living proof that you can live a pretty much a normal life. So it's not all doom and gloom. And with the advances in medicines and technology coming up, it would definitely just keep improving from there on in.
Absolutely.
So.
Absolutely. And John?
Yeah, no, I think it's a measure of hope, Ashta. There's been tremendous progression in the last 40. I'm 40 something years qualified now. I nearly forget, that's the brain. But the advances have been really quite enormous, and they're still coming, and there will be more. There's no doubt. Medical science, that's the way medical science is, and research. So I think the message has to be one of hope. I think it's very important that people hear their doctors, hear their nurses, hear their psychologists, follow the programs, do the self-help as well. And you can have a good quality of life. There's no question about that. A very good quality of life. So that's the main message. I was a little bit saddened to hear in your story, actually, because the initial doctor that you may have seen said, no, you don't have any major problem, you don't have any major heart pumping and stuff like that. So I think for younger people, and when younger people have symptoms, particularly palpitations or feeling as of pressures in the chest, it's very important that doctors listen, And of course, heart failure isn't terribly common in young people. It's something we see in older age, old fellas like me, So doctors get they miss the diagnosis. And we have to admit that sometimes we miss the diagnosis. And so it's so important to listen. For doctors, it's so important to listen. So if you have a complaint as a patient, bang on the door and say, I'm not happy, this ain't good enough. And if I'm not getting satisfaction with a doctor, then I'm going to another doctor. And that's what Ian ultimately did, and found the doctor who did an ECG, etc. on him. And so that's what you have to do. You have to empower yourself. But emphasize to the doctor, look, you're unwell, you feel unwell, and it's not in your head.
Absolutely, absolutely. I could agree. And I could say probably from my point of view that, it really from this conversation today, we see that there is definitely a hope in the future for the patients. And from my point of view, I would like to encourage those who are living with a heart failure to live well, stay positive, and get educated. I think that's very important, and take the control of your own disease. So I would like to thank you all for participating, and it was delightful to host this talk. And I would like to pass the word to Annie, who will conclude this discussion. Thank you very much.
Thank you, Aiste. And can I just say an heartfelt thank you to all of you. That has been an absolutely amazing conversation. I hope that our audience have found it hugely beneficial. It will be shared on our website from tomorrow afternoon, and anybody that has registered and wasn't able to watch it or would like to watch it back, they will receive the recording tomorrow evening. But to our panel of experts, and you were all experts, to our patient experts, to Aiste and Ian, thank you so much for sharing your stories and your honesty and your openness. That's just been amazing. And to John and Emer, again, thank you so much for giving your time and for sharing your expertise and your insights. It's been truly, truly wonderful. So thank you all. I really, really do appreciate it. And for anybody who is on the call this evening or who is watching this back later on and has any questions or queries that maybe weren't addressed this evening with regard to heart failure, or indeed anything related to your heart health, please do know that we have a free nurse helpline, our HeartLink West helpline. It is available from Monday to Friday, 9 a.m. to 5:30, and you will make contact with our lead nurse, Maeve Frawley, who is working away in the background here this evening, on 091 544 310, or you can email us at healthteam@croí.ie. You will initially chat with Maeve, and if need be, you will be directed along to the rest of our multidisciplinary team of cardiovascular nurse specialists, physiotherapists, dietitian, and health psychologists. So please don't hesitate to lift the phone and give us a call if you have any questions or queries. You also might like to know about a weekly virtual chat that we hold that's hosted by our the Croí multidisciplinary health team. So there's a different member of the health team who delivers a chat every Thursday at 11 a.m. If you go to the website, you'll see all the lists of upcoming talks to the end of the year, and you can log on there and register for the talk that interests you most. Those talks, I should say, are not recorded. The idea of those talks is that it is a virtual face-to-face with the healthcare professional, and it's an opportunity for you in a small Zoom session to pose your questions directly and get a direct answer. So that's the logic behind that. So this episode this evening was part of Croí's Living Well with Cardiovascular Disease series, and our next episode will be focusing on atrial fibrillation. So I ask you all to save the date, Thursday the 9th of June from 7 to 8 p.m, where we will be joined by another panel of experts, patient expert and experts from the clinical world, to discuss living well with atrial fibrillation. And I think that is the one thing that I hope, and certainly I've taken from the conversation this evening, is that albeit you are living with a chronic condition, there is hope, and there is no reason why you should not be living, as Emer said, your best life. And there are lots of supports and help there to help you do that. So with that, I would like to say thank you for joining, and we will see you next time. Take care. Thanks, everyone.
Thanks so much. Bye-bye.
Thank you.